Okay. So in your OSCE, so as medical registrars, you are expected to identify ischemia. In your OSCE, there's a very high chance that you are being given a ECG with some sort of ischemia. So in this ECG, what do you see? And so the question is the diagnosis and what is the artery affected. So anyone can comment.
2-3 AVF ST elevations,
Very good.
more suggestive of inferior STEMI, the
Okay.
affected artery, complete occlusion of right coronary artery.
Very good. So you have mentioned that there's ST3 elevations in 2-3 AVF, and so possible culprit vessel would be right coronary artery. What else do you see? If they give you the question like describe the ECG changes here, what else? And usually if they ask the diagnosis here, you have to give the complete diagnosis, because now they have to give the marks and select only very few of you. I know that all of you are having certain level of competency, so they will select the best answer. So you should not miss things.
There was a
Yeah.
bradycardia and the type 2 heart block is there, sir.
Yeah. Okay. So there's a heart block, and since it is only not like total dissociation and only one miss beat, this is Mobitz type 2, correct? Right. So other than ST elevations, what else do you see in this ECG?
Reciprocal ST
Q wave is
depression
there,
of one
prominent
Yeah,
Q wave.
very good. Very good. So the Q waves are there. And so remember, at the time, there was an impression that when there's Q waves, the infarction is complete. But now the thoughts are different. So the Q waves can come depending on the individual in different times. So having a Q wave doesn't mean that patient is not suitable for any sort of interventions. Nowadays, what we mainly consider is the first and foremost is the time, but the other thing is the chest pain, ongoing chest pain. And so remember, you should know what are the territories like. So these are simple basics. I will just revise it. So if the changes are in 2-3 AVF, usually it is inferior. And remember, inferior ischemia can give reciprocal changes to lateral. So it could be in V5, V6, or lead 1 and AVL. So you have to see whether there are any changes in. So do you see the AVL ST depressions here? So there's a ST depression in AVL. So it's a reciprocal change. Okay. And then you have to see, especially when it comes to RC arterial infarction, RC, right coronary artery, is the one which is giving, mostly giving supply to SA node, AV node, and most of the conduction system. So they can give even inferior ST elevation MI with complete heart block, right? And the other thing, usually the artery which supplies to the inferior part of the heart is can supply to the posterior also. So this can be associated with inferior infarction extending to posterior area. So if so, what is the ECG change you will see?
Tall R wave in the V1 to V3.
Yeah, very good. So there can be tall R wave if there are Q waves in the posterior side. And then there will be ST depressions in the V1, V2, V3, that area. So then the other question they can ask is, now they can ask what is your complete diagnosis? So it can be provided that if you think that there's posterior changes also, this is inferior ST elevation MI with posterior extension complicated with the complete heart block. So the next thing they will ask is, how will you confirm the diagnosis? Oh, what is the ECG you have to take? So what is the ECG you have to take then?
V7, V8 and V9 leads.
Yeah, so you have to request for V7, V8, V9. And always you can request at the same time. What is the other lead we are requesting?
V4R to
V4R.
V4R.
Yeah, V4R, because it can involve again the right side RV infarctions, and then the management will differ. So again, may I ask if there's RV infarction and patient present is hypotension. So they might say, so remember in your OSCE, it is not usually just a ECG, just a picture and all. There will be always a clinical scenario, right? So if there's blood pressure, low blood pressure with possible RV infarction, what is the salient thing in the management? So as a registrar, what should you do to improve the blood pressure?
We can give fluids.
Yeah, very good. So you can give fluids. In order to do what? What is the pathophysiological basis of giving fluids? What you will do?
Increasing the preload of the
Yeah, very good. So we are going to increase the preload. So according to the Frank-Starling curve, the contractions will be more. So remember, if the blood pressure is due to LV infarction, usually we have to use inotropes. And if we give fluid, patient will end up in pulmonary edema. But if it is a RV infarction, the modality of treatment is giving fluids, right? So remember, so you can get any ischemia ECG and you must not miss it because you will be the people who will guarding the door to needle time. What is the door to needle time? Again, they can ask. What is the usual door to needle time? You know, door to needle time means giving fibrinolysis if you don't have the facilities to do PCI, primary PCI. So what should be the door to needle time in a person who's having acute ST elevation MIs?
60 minutes.
So yeah, one answer 60 minutes, one answer 20 minutes. What else?
90 minutes.
90 minutes, yes. Yeah, so that means you are not that clear. So remember, there's two entities you should know, and it is very important as registrars also. One thing is door to needle time, the other thing is door to balloon time, or nowadays we call door to wire time, right? So door to needle time is usually 30 minutes, right? That means when you see the patient first, or when the patient enters to the ward, you have to give fibrinolysis within 30 minutes. That's why if you have to take the ECG before, I mean, if it is a typical chest pain, you have to take the ECG within 10 to 15 minutes at least, unless you can't do that. And door to balloon time or door to wire time means usually 90 to 120 minutes. So previously it was 90 minutes. Now they, in some guidelines, it say 120 minutes. But remember, you are the person who will decide whether you are going for the fibrinolysis or not. So you should know this fact. Because sometimes the other end, let's say you are calling to a PCI center and they don't know how much time you will need to arrange the ambulance and what is the traffic situation in the area and all. So remember, within the first 3 hours, the fibrinolysis, I mean, the achievement of patency from fibrinolytics and primary PCI is the same, right? So always we can go for the rescue PCI if it's not working, but you have to give the fibrinolysis. So the management of choice, I mean, what is the specific drug you give in these instances they can have? Then here, what we are now going to say is IV tenecteplase, right? Because the tenecteplase is the one which has most of the trials and evidence of high patency rates. Sometimes back it was streptokinase, and recently also we were using streptokinase, but tenecteplase is the drug of choice, right? Okay. So remember ischemia, ST elevations, and whether there are any other associated territories. So you should know. So 2-3 IVF is inferior. AVL, lead 1 is high lateral, V5, V6 low lateral, and then V2, V3, so V1, V2, V3, that area posterior, and then V2, V3, V4, V5 comes anterior. It's the whole thing. It can be extensive anterior, what we call anterolateral. Right? Any questions? Yeah, I can't hear. Do you have any questions? So in this ECG, let's say, what are the things you see? What are the abnormalities you see here? Again, comment.
It's S1, Q3, T3.
You have S1. You have a Q in the... So very good. I mean, your way of thinking is correct, right? Because the patient has presented dyspneas. Yeah. So jolly well, this can be pulmonary embolism, right? But you don't see good teen versions here, right? But you have to always think about pulmonary embolism. Good. And what else? What are the other changes here? Very good. So that shows, so V1, V2 ST depressions with right axis deviation, that shows there are some RV strain, right? So again, it is more suggestive of some sort of sudden RV stress, right? What else? There's another one thing here. Yeah. And if you see the rhythm strip, you can see there's you know. So is this sinus tachycardia, Lamai? What do you see? What do you see here? Is it sinus tachycardia? Or is it something else? So you don't see, you know, particular same unimorphological P waves, isn't it? So there are different morphologies of P. And definition-wise, 3 or more P with a rate of more than 100. What is it then? Rhythm-wise, this is not sinus tachycardia. So what is this? It's a multifocal atrial tachycardia, right? So remember, a person who's having any sort of straight atrial stretch can again present with this. So even in a pulmonary embolism, multifocal atrial tachycardia can happen. Or even in a person with lower respiratory tract infection, this is a common rhythm abnormality we are seeing, multifocal atrial tachycardia. So always see the rhythm strip because that will give you the rough idea about the rhythm, whether the patient is having a block or not, and then the shapes of the P waves and QRS and all. So usually the rhythm strip is lead 2, right? Okay, so always see what is the history they have given because that will invariably give some sort of hint to you. Whatsoever the OSCE station, not only the ECG, but whatsoever, right? So this one again, there's a history. Middle-aged male found unconscious on roadside. So like I told, these are the previous OSCE questions. That's why, so most probably you will be able to identify this. So what is this? Anyone?
SVT,
Sorry?
supraventricular tachycardia.
So there's a tachycardia. Looks like sinus tachycardia. So, but that doesn't give us much information from the ECG, So they won't give you in the OSCE just the sinus tachycardia ECG. So there should be something hidden. What else? If you see, now here, there's axis change, right? So what is the axis here? Is it right axis deviation or left axis deviation? Yeah, it's right axis deviation. So remember, if the lead 1 is negative, that is enough for you to say it's right axis deviation. But for you to tell left axis deviation, both lead 2 and 3 should be negative, where the lead 1 should be positive, right? Only lead 1 will be positive. Here you know that even not only lead 1, even the lead 2 is negative. So there's right axis deviation. And you can't exactly see it here because ideally you have to do the corrected QT, but here the QT is prolonged, right? And if you see AVR, there's usually the AVR, the main QRS morphology should be negative, right? But here, if you see, there's a terminal R, which is, so it is a simple Q and R. That means the Q wave R is taller than the Q depth, right? So if you go back to the history, they have found unconscious. With these changes, so it is usually a TCA overdose, right? So this is something they have given, and clinically we might not see these things this much, but get into your heads that you have to always think about the short history they are giving. Then only you can think what this can be, right? And so remember, this is something they have given previously. So with these sort of things, they can develop the question like this, isn't it? So this is from 2017 OSCE. So they can develop the whole question. What is the ECG diagnosis? What are the ethical principles in treating this patient? So those things I think you should know and you have to. So what are the ethical principles treating in this patient? So the patient refuses treatment, let's say. So you should remember there are now these things you should know because in clinical now not only in the ECG things but ethical questions can be asked in any OSCE station. So always think there are 4 main pillars in when it comes to medical ethics, no? Autonomy, justice, beneficence, and non-maleficence, right? So this patient, we can't give the autonomy, right? But we have to do the beneficence and both non-maleficence. So those are the 2 pillars and you can just write that, right? So think in that line. Just read about this because it can be asked, right? Even in any other OSCE stations. So then you should know what is the antidote. And then ICU bed 3 facts to prioritize this patient, and you of you have worked in the medical wards and clinical setup, then you know how in Sri Lankan setup we do these prioritizations. So I'm not going into detail. So here 40-year-old male with chest pain. So when we tell chest pain, you know that you have to first see whether there's any ischemic changes. So this is a bit unclear ECG, but there are some ischemic changes. What are they? Somewhat V3, V4, V5. So what are the other ECG changes here? There's now if they can ask, just list the ECG changes. So what else? So go in a sequential manner. Rate, rhythm, and then the P waves, QRS, ST segment, T waves, and anything else. So here, what about the rate?
Tachycardia.
Yeah, it's tachycardia and it's sinus tachycardia, isn't it? And then what do you think about the R wave progression? Is it normal here or not?
R wave progression.
Yeah, so there's poor R wave progression. What's the definition of poor R wave progression? So how will you say poor R wave progression? Usually it is in V3, the R wave is less than 2 millimeters, right? So usually less in V3, usually it will be 3 or more. So here it is around 1 or 2, less than 2, right? So this shows that actually this might be well into so V3, V4, V5. So it may be it is anterior ST elevation MI with tachycardia due to the pain and the response. Okay. So what is this ECG? Anyone can comment. I will give few seconds.
Trifascicular block.
Trifascicular block. Any other takers? Now, when you see something like this, which is abnormal, now you see the QRS complex is wide, isn't it? It's wide. And the other thing is, if you see the rhythm strip, and even if you see the AVR lead, the axis is totally changed mostly, right? So, and you can't see particular P waves. So, actually, this is a rhythm which is arising from the ventricle. But it is not fast enough to say VT, ventricular tachycardia. So what do you call this?
Idioventricular.
Yeah, accelerated idioventricular rhythm. Right. If this is less than 60 or 50, we can tell it is a ventricular escape rhythm. Usually it won't happen unless there's a severe sick sinus syndrome or there's a complete heart block. But here, so if you see the rhythm strip again, right, you can see that there's a sinus beat suddenly coming. 1, 2, 3, 4, fifth beat. And so fifth beat is a total sinus beat, right? Fourth beat is a fusion beat. Okay. What is sinus beat? What we call capture beat. And the beat before we call fusion beat. What's the capture beat and fusion beat? Physiology of this beat. In a capture beat, what happens is before the ventricular focus fire up, the normal, because even tachycardia happens, doesn't function. Only thing is the ventricular rhythm overtakes it, right? The whole heart is a pacemaker. But usually the sinus node is the predominant area which produces the signal. That's why we say in a normal person, we can see sinus rhythm. But if there's another focus, that focus will take over. So still the sinus rhythm will do its job. But the problem is due to the other person is acting more rapidly, we won't see that sinus activity. But once in a while, the sinus beat can penetrate through the AV node and spread in the normal conduction system. That is called a capture beat. So once when the next beat comes from the ventricular ectopic, the ventricle is in the refractory period. We know that cardiac muscles are in a refractory period. So that's why it doesn't produce a normal ventricular tachycardia or ventricular ectopic beat, but the normal QRS complex. This is called the capture beat, right? Sometimes what happens, part of the ventricle will be depolarized by the ventricular ectopic and part will be depolarized from the upcoming sinus beat. That is called a fusion beat. So remember, in a rhythm strip, if you see wide complex tachycardia, you see a fusion beat or a capture beat that is pathognomonic for VT, right? That's why you have to see in a rhythm strip. If you are having, say, sometimes there are broad complex tachycardias where you are not sure whether this is bundle or whether this is aberrancy or whether this is pre-excitation, something like that. But still, if you see a capture or a beat or a fusion beat, you can definitely say, no, here say this is having this, so this should be a VT, right? Right, okay. Okay. So just to summarize accelerated rhythm here, the rate is not as fast as you for you to say that it's a ventricular tachycardia, and it's not as slow as to say it's a ventricular escape rhythm, right? So again, this is the same thing. I will just. So remember here, actually, this is the ventricular escape rhythm, which is also called just the idioventricular rhythm, not accelerated, where the sinus node is not functioning at all, right? So usually what happens when there's a severe sick sinus syndrome is either AV node will take over, but sometimes the AV node also is involved in the fibrosis process. So sometimes people come with ventricular escape rhythm. So as a registrar, if you get a bradycardia patient with a ventricular escape rhythm, that patient is likely to be having unstable rhythm, right? But if it's a nodal escape, usually the node is stable. So just remember that. So how will we differentiate? In a nodal escape rhythm, the node is the place where the ventricular impulse is originated. So the QRS complex will be normal. Only difference is you don't see P waves, and then it is slow, right? This is just theory. I don't want to burden you. We'll discuss the ECGs, right? Okay. So again, another chest painting. Now we have already discussed. So now you can give a complete diagnosis for this patient. Tell me. So what this ECG shows?
Inferior sternally
Yeah,
posterior extension.
it is a inferior STA elevation with posterior extension, right? So one thing you can do is to do a V7 to V9, and the other rapid thing you can do is you can just turn the ECG upside down and look from behind. Then again you will see the ST ups, right? Okay, let's see this question. 28-year-old previously well male who was having fever and headache with loss of appetite and loss of weight for 1 month duration. Found to have unconsciousness in the morning by his mother. On admission to the ATU, he was drowsy, GCS low. So, okay, now there's the ECG. So what is the abnormality seen in this ECG? Anyone?
Tall T waves,
Very good. So
hyperkalemia.
tall peak T waves. So what usually when we see tall peak T waves? When there's hyperkalemia. So remember, this is a ECG you should not miss, because the next time the patient might be having sinus waves and then it may be just peri-arrest. So you have to treat this patient because there are ECG changes caused by this, and you can, so they can ask in this question, so how will you confirm your diagnosis at both settings? So very quickly you want to do a test. So ECG is there now. One thing you will say hyperkalemia ECG. What is the other thing? If the facilities are available in the ETU setup or ward setup, you will do. What is the bedside test?
ABG.
ABG. Very good. So remember, as registrars, two tests are very, very important in situations where you are facing, a dilemma. One thing is the CBS. The other thing is the ABG. So ABG gives you a lot of information. It talks about the oxygenation. It talks about the lactate. It talks about the pH. It talks about the potassium, sodium, rough value, and hemoglobin, right? Even if a patient comes with ST elevation MI, so these are the real life scenario cases. So we have seen some people have given fibrinolysis for people, young female having menorrhagia, coming with ST elevation, fibrinolysis, and then, very disastrous consequences. So if you suspect the patient is having low HB, do a ABG, right? Or VBG. VBG is enough at that time, right? Okay. So I am not going to talk about the hyperkalemia management. You should know, right? And then these LP also. So LP interpretation is expected to you again, expected from you. So tell me what are the DDs for this? So they are asking two explanations for this. So if you see protein levels are high, there are red cells, and then sugars low compared to the blood CBS, and then lymphocytes are high. So what can this be? Yeah,
ED
so if you see
meningitis.
the history, very good. If you see the history, it is a subacute meningitis like picture. So this can well be TB meningitis. What else?
Fungal meningitis.
Yes?
Fungal
Viral,
meningitis.
Fungal.
viral meningitis, viral.
Yes, so this can be partially treated
herpes
meningitis
encephalitis.
also, isn't it? Because now the patient was having this problem for a long time. So they might have gone for something. So partially treated, this thing is also correct. And so just go through this, CSF interpretations, because they can jolly well ask that, because you are the ones who will perform the CSF LPs and then interpreting it, right? Okay. So again, more or less the same. So usually they can give the hyperkalemia ECGs telling that the patient is having CKD, right? That is why I have put the same thing here, right? So heart failure in the ICU day 7. So remember, a person in the ICU can always have electrolyte imbalances, okay? And the other thing, they can have ischemia. They can have hypothermia, right? So when it comes to the ECGs, we are worried about 3 electrolytes. Can you name them? When it comes to ECGs, we are worried about 3 electrolytes. What are they?
Potassium, magnesium,
Potassium,
calcium.
magnesium, and calcium. Very
Magnesium,
good.
calcium.
So remember,
Calcium.
sodium won't give us trouble with the heart, right? It's the brain thing. But heart, these are the 3 things, right? So here, if you see, patient is having a U wave, okay? So this is a patient who's having hypokalemia in the ICU state, right? So just go through what are, so usually if the EC changes are there, that means potassium is less than 2.7, okay? Sometimes U wave can be hidden in the T wave, and we might think that it's just long QT. And the other thing, if you want to U wave, just look carefully in the V2, V3, V4, those leads. Those are the leads. Usually we will see the U waves. Okay. Let's see this one. A 75-year-old female with a history of diabetes, hypertension, and past history of TIAs, 2 times TIAs, presents to the ETU with chest tightness and palpitations for 2 days duration. On examination, her pulse rate is 155, so tachycardia, but irregular, right? BP 148/74, and no cardiac murmurs, lung bases are clear. So what is the ECG diagnosis?
Atrial fibrillation.
Sorry?
Atrial fibrillation.
Okay, good. Atrial fibrillation. Will you stop only with that? Which sort of atrial fibrillation? It's a fast atrial fibrillation, or you can mention heart failure with high ventricular response. Right? So that is the diagnosis. And if you see here, so they have already given you a lot of hints, no? Past history of 2 times TIAs, right? And they are telling no cardiac murmurs, and they can even say there's a cardiac murmur if it's a young person, right? Then, so if a young person has atrial fibrillation and a cardiac murmur, what that cardiac murmur can be?
Mitral stenosis.
Yeah, so what is the murmur you would like to hear? And what is the probable diagnosis? So there are 2 things. So mitral stenosis murmur would be what? It's a mid-diastolic murmur, right? Probable diagnosis is mitral stenosis complicated with atrial fibrillation and TIAs, right? Okay. So these are the questions they have asked at that time. What is your initial management of this patient? So how will you manage this patient initially? So we
IV
have
beta.
two priorities when it comes to atrial fibrillation. What are those two? One thing is controlling rate.
Rate
Yeah. What is the other priority? Preventing
preventing
thromboembolism, embolic strokes, right? So you have to start anticoagulation, provided that there are no contraindications, and you have to start rate control drugs. So what are the rate control drugs you are starting at this stage? Yes?
IV beta blockers.
Yeah. So beta blockers and or calcium channel blockers. And remember, digoxin is not first line nowadays, right? And then, remember, if it's a person, young person who has a particular clear-cut onset of the arrhythmia, you can always go for a if the presentation is less than 12 hours. So in your history, they might be telling patient is coming with palpitations for 2 hours duration and no other history. This is the ECG. What is your preferred way of management? So in those people, always you can do cardioversion. It can be chemical or it can be electrical. But remember that the time gap usually is 12 to 24 hours. But after 24 hours, we will always anticoagulate them at least for 4 weeks and then cardiovert. Or if we want to cardiovert them very quickly, what is the other option we can do?
Transesophageal
Very
echo
good. We
and
can
look
do a
for the
TOE to see LA clots, right? To be specific, LA appendageal clots, right? So nowadays, rhythm control is always preferred in people with atrial fibrillation. Those days, evidence has shown that rhythm control and rate control won't that much affect the survival benefits. But quality wise, now they have noted that if the patient is in normal rhythm, even though they don't feel atrial fibrillation, their quality of life will be improved, right? So you should know. So investigations wise, how will you do in an atrial fibrillation patient? Tell me
thyroid
2
function
investigations
test.
you want to do. Now, this is your OSCE question.
Thyroid function test
Yeah,
and
very
the
good.
serum
Thyroid function
electrolyte
test. And
and serum electrolyte.
Full blood count.
I think anything you can, justify, but best 2 things you will see for your exam, I think you can just mention echocardiogram and TSH, right? How would you decide on her further management? So whatsoever. So remember, this is a golden rule. If a patient has tachycardia and hemodynamically unstable, what does that mean? That means patient's blood pressure is less than systolic 90 and diastolic less than 50 or 60. Mind you, you're not a computer, so blood pressure in a patient with heart failure may be anyway low. So it may be 80/50 anyway for him. I'm not talking like that. For any person, there's a sudden drop due to tachycardia. You don't have to worry about the diagnosis. What is the management? It's cardio. Is it cardioversion or defibrillation? So remember, it's cardioversion,
Cardioversion.
right? It's cardioversion because defibrillation, there's only 2 indications. What are the 2 indications for defibrillation?
Pulseless
Pulseless VT and
VF.
VF.
Pulseless VTM.
We are not worried about whether we are giving the pulse on RO, TO, anywhere, because anyway patient is not perfusing in those 2 rhythms, right? But any other rhythm, even though the blood pressure is dropped, let's say the blood pressure is 70/40. And if you are just giving a defibrillation means you are not considering the places where the T wave is there, QRS and T. So if you give the shock on the top of that, patient will go into a non-perfused rhythm, VF. So you are doing harm, right? So remember, as registrars or as medical officers, always do cardioversion if it is not pulseless VT or VF, right? Always cardioversion. Unless you are doing more harm to the patient, right? And you should know how to do cardioversion. Sometimes they might expect you in your this OSCE CP if there's a CPR station. So you should connect the patient to the defibrillator, right? Not for the normal monitor. And then only the defibrillator can differentiate. And you have to push the synchronize button. So those are the two prerequisites. Connect the patient to the defibrillator by ECG and then push in the synchronize button. So if you do those two things, machine will do the cardioversion, unless it will always do the defibrillation, right? Okay. So we'll go to the next question. So this is again, at one time they have given a E.C.G list two abnormalities. So it can be the rhythm and the rate and whatsoever the abnormality there. What is the complete diagnosis? What are the complications? So complications in AF is usually two lines. One thing is the heart failure due to tachycardia, and then the other thing is the thromboembolic strokes, right? What did you assess in 2D echo? So you have to see the cardiac function, LV functions, and especially mitral valve, whether there's mitral stenosis or valvular issues, and then chamber dilatations, right? Okay. So since we have discussed about this atrial fibrillation, how they can give atrial fibrillation ECGs in your OSCE. So this is one ECG they can give. So 63-year-old male soon after CABG, right? So this is a common thing we will see after cardiac surgery or any other surgery or any other medical illness. A person who's not previously had atrial fibrillation due to the stress, surgical or acute medical, they can have atrial fibrillation, right? So you should be able to identify that. And remember, again, the management is the same way we discussed, either rhythm or rate, depending on the patient's hemodynamical stability and how long it has been there. And then the prevention of thromboembolism, right? And you use, what is the score you use to decide on whether the patient need long-term anticoagulation?
Chadwell score.
Chadwell score. So be familiar with the Chadwell score, because even they can give history and ask what is the Chadwell score of this patient, right? Because that is the, people with non-valvular AF or other special circumstances like hypertrophic cardiomyopathy, all the other people, we use this Chadwell score, right? Other people, we anyway give anticoagulation. Okay. So don't, so these things you should know, but for your ski purposes, remember, they can ask. So what is this? The history is 85-year-old defaulted follow-up, VVI PPM. And now coming with this, and let's say patient came with a syncopal event. VVI PPM means it's a single chamber pacemaker pacing ventricle, right? Right ventricle. What do you see here? What is the rhythm? Is it sinus rhythm? Oh, shall I ask, do you see the P waves here?
Yes,
Yes
sir.
or no?
Yes, sir.
You don't see well-formed P waves, huh?
No.
So this is actually slow atrial fibrillation, right? Slow atrial fibrillation. And is the pacemaker working here now? So if they ask the complete diagnosis here, it should be slow atrial fibrillation with non-functioning pacemaker. That is the whole reason why she had the, because pacemakers are, programmed in such a way that they should be paced at least by 60 or 50. Usually we won't keep it below that if it's not an ICD, right? So here, if you see this 1, 2, 3, 4, fourth beat and the fifth beat, the gap is so far away. If the pacemaker is working, it will just give a pacing spike at that time, but it's not giving, right? That means there's a pacemaker malfunction. Okay, right. So 57-year-old lady with palpitations. This is just, additional knowledge. I don't think they will ask this. Now here you might miss. Now this is again, what is the rhythm here? What is the rhythm?
AF.
Yeah, it's fast AF, isn't it? It's fast AF. And you see some other, abnormal QRS complexes, isn't it? So this is something we do see in atrial fibrillation patients, which is normal. This is due to conduction aberrancy, which is called Asherman phenomenon. But these are not ventricular ectopics. Huh? This is conduction aberrancy, usually which happens followed by a long coupling interval, right? That means when there's a pause and then suddenly one QRS comes and the next QRS comes very quickly, then they will get some sort of aberrancy due to the refractory properties of the conduction system. Okay, this is again a OSCE ECG. Tell me, what is this? 70-year-old male presenting with pre-syncope.
Bradycardia.
Yeah, so good. You have identified that there's bradycardia. Bradycardia is not a diagnosis. It's just describing the rate. What is the diagnosis?
Slow wave.
Slow wave. Slow wave.
Sorry?
Slow wave.
Slow wave. Okay. Improve on your answer. Is it just slow wave? If you give slow wave, you might get just half marks and your colleague might give
Small
the...
complexes.
Yes?
Small complexes.
Sorry?
Small complexes.
No, that's not what is expected.
Flutter waves.
Yeah.
If with
So
complete heart
remember,
block.
this is there's a very big misunderstanding about this flutter waves and flutter fibrillation diagnosis. So remember, there's no entity called flutter fibrillation. Flutter can degenerate into fibrillation, but it cannot be there in the same ECG, right? Same ECG means in one ECG fibrillation and one lead flutter. Remember, atrial flutter, simple thing. This is a simple rule. If it is atrial flutter, the maximum rate the flutter waves can be there is 300 per minute, right? 300 per minute means in a large square, how many flutter waves you can see in one single large square? It's just one, right? Because there are 300 large squares per minute. So if it is a atrial flutter at any ECG, usually there will be one flutter wave for one large square. But here, if you see in V1 and V2, let's say take about 3. If you see in 3 large squares, there's about 4 waves. So this is physiologically incompatible, right? Flutter means a macro circuit. The whole impulse goes around the tricuspid annulus. So we have physiological limitations. That is the conduction velocity of the cardiac muscles. So the maximum velocity it can go is 300 per minute. So this is incompatible. The other thing, in any atrial fibrillation, there can be organized fibrillatory waves. And usually you see these waves in V1 and V2. So don't take them as flutter. Okay. So that is a learning point. And the other thing, in atrial fibrillation, what do you expect the rhythm to be? Is it regular or irregular? In atrial fibrillation?
Irregular.
Irregular. In this ECG, is it regular or irregular?
Somewhat regular.
It's regular. So other than atrial fibrillation, you say atrial fibrillation because there's no P waves. There's something else. What is it?
Complete heart block.
Atrial fibrillation with complete heart block. Right? So that is the complete answer. Now see here, this ECG I have shown you. If they want you to give more with the ECG interpretation, they can give a thing. Atrial fibrillation with ischemic changes. Remember, ischemic changes means always QRST changes. Right? Fibrillation means it's just the rhythm. Right? So having atrial fibrillation doesn't prevent you from diagnosing ischemic changes. So always, if there are ischemic changes, that is a separate diagnosis, right? So here you can see ST elevation says 2-3 AVF and reciprocal ST depressions, right? So maybe this MI has caused the atrial fibrillation on presentation. At that time, you just don't treat the atrial fibrillation. You have to treat the MI, right? So it's the hand in hand. It goes hand in hand. And remember, when it comes to ischemic changes, what should we look for? ST elevations, ST depressions, Q waves, T inversions. Is that all? It can be, remember, this is for your knowledge, it can be T normalization. Because in a person who had previous T inversions in the chronic ECG, next time he comes with typical chest pain, when you do the ECG, if you just see that ECG, patient hasn't drawn the old ECG also, it might be a normal T waves. That's why all these investigations, though it is ECG, ABG, electrolytes, whatsoever, you are not treating the investigation, it's the patient. If the patient has ischemic chest pain, ECG normal, what is the next thing you have to do?
Cardiac enzymes, troponin.
Yeah, cardiac enzyme will take time, isn't it? You have to repeat the ECG and see for dynamicity, right? So the salient thing which you see for ischemia diagnosis is dynamicity, not the tropi, because tropi can be negative in unstable angina patients, right? Okay. So again, patient 62-year-old male presented with epigastric burning pain for 2 hours since 3 a.m. He was admitted to the hospital at 8 a.m. and following ECG was taken, right? So this now you should be able to tell now, very easy. Yes, what do you see here? Tell me, just describe the ECG. Very good. So there are ST elevation. Remember 2-3 AVF, even 1 millimeter is enough for us to tell that there's ST elevations. What else? Yeah, very good. So there are reciprocal AVL ST depressions as well as some V2, V3 area also ST depressions, right? So, and there's a, we can't, if you see the rhythm strip, there's a blocked P wave, right? Okay. So what is the complete ECG diagnosis? We have already discussed. What is the additional ECG you want to perform to confirm it? So you here, you can, now sometimes they might have given the blood pressure also, right? Then you have to do a V4R because it's the right side, this thing. And then you can do V7, V9 also to see whether there's any posterior involvement, right? And what is, so if it is a RV infarction, this thing, you have to give this fluid and then the patient's blood pressure will improve. Now here, this is just, this is a very common question. Now, after acute treatment in his blood pressure, heart rate 96, HbA1c 6.8, lipid profile is shown here, right? Ejection fraction 35%. Renal and liver profile was normal. He does not have any drug allergies or bronchial asthma or COPD, right? So tell me, what will you prescribe for him? So it's not just the drugs, huh? You should know how to write a proper prescription. I'm not going into detail onto that. So you have to write a prescription. So you have to write a proper prescription, name, age, those things, date, those things, they will give marks. But I will just discuss the drugs. So what are the drugs you will give here?
Oral spironolactone, we can start it.
Okay, spironolactone, good.
ACE inhibitor,
And
ACE inhibitors,
oral
beta block,
bisoprolol.
beta blockers.
And
Atavast-
as HbA1c is high, we can start SGLT2 inhibitors, empagliflozin.
Yeah, okay. So what usually you will start either empagliflozin or dapagliflozin, isn't it? That's what available to us. So what else? So do
Atavastrin
you
powder,
give, so here do you give ACE inhibitors as first line? What is the first line in nowadays guidelines?
ANI,
Yeah, very good. ANI, right? So you have to give sacubitril valsartan. That is the first line. Because the patient's EF is low, right? So in a person with low EF, patient must be on 4 drugs, right? That is ANI, beta blockers, mineral corticoid receptor agonist, spironolactone or epinol, and then empagliflozin or dapagliflozin, right? Sodium glucose cotransporter inhibitors. And then this patient has had a MI. Any MI patient before discharge, patient should be on 5 drugs. What are they? Again, yeah, aspirin, Clopidogrel,
Clopidogrel, atorvastatin.
atorvastatin, high intensity atorvastatin, right? That's why you should write your prescription properly. Atorvastatin should be at least 40, right?
40.
And then
AC inhibitor.
ACE inhibitors, but here we are giving ANI, right? So those are the 5. Okay.
Sir, can we write rosuvastatin 20 or
Again, yeah, rosuvastatin either 20 or even if you write rosuvastatin 40, I will take it as correct, right?
Okay.
Because high intensity means now here in Sri Lanka, we don't give atorvastatin 80, but usually because of our body habitus, but that's how, it is recommended. So highest dose tolerable, right? Okay.
So for the ischemia, aspirin and Persuadrol can be given.
Yeah, so that depends. So in your circumstances, I think you can just tell aspirin and clopidogrel and it will be correct, right? Giving ticagrelor or giving pasugrel, so that is a decision comes by the cardiologist. So we consider different things, right? So if a patient has had a long stent, usually we like to keep the patient on ticagrelor. If a patient we are going to manage with medications and all, we like to give pasugrel. So those things, I think in your circumstances, better to tell clopidogrel and don't make it complicated, right? Only thing is patient must be on dual antiplatelets in that prescription, right? And remember that is for 1 year. Even when you are in your medical clinics, you will see people are on medication, these dual antiplatelets again, on and on and on. And we don't know, a lot of them die due to different causes, ICH, GI bleeding and all. So it's only 1 year, right? That is just for your practical purposes. Now see, this is another way they can develop the question. 2 weeks after discharge, patient presented with the ward due to some complaint. And the following ECG is here. What do you see here?
Diffuse ST elevation in
Very
several
good.
multiple.
Diffuse ST elevation. Can you elaborate? Which sort of ST elevation?
Saddle-like.
Yes.
Saddle shape.
Saddle shape. Yeah. Saddle shape ST elevations. Good. What else? What else you see?
PR depression.
Yeah. So there's PR segment depression. And when it comes to AVR, PR segment elevation. So what is the diagnosis here?
pericarditis?
Yeah. So pericarditis, usually this happens after MI, and then we call this
Restless syndrome.
Restless syndrome. So read about it. And what would be the presenting complaint in this patient? What would have been the presenting complaint?
The chest pain relieving when bending forward.
Yeah. So it is a pericarditis chest pain, right? And just know what we can do for this, right? So usually we can give high dose of NSAIDs and colchicine, right? So these things you ask in the history, examination find. So examination findings, what can there be? Huh?
Pericardial rub.
Yeah, very good.
Reduced
Pericardial
heart
rub.
sound.
Muffled heart sound, very good. Laboratory findings, what will you expect?
Yes, sir.
Yes? Yeah, so the elevated inflammatory markers. So ideally speaking, these people must have an echocardiogram prior discharge to see whether there's any developing effusions, right? A 58-year-old male driver, previously healthy, present with epigastric burning type chest pain, sweating and vomiting for 1 hour duration. Pulse rate 50 beats per minute and blood pressure 120/70. ECG is this. So what do you see here? Yes, give me the complete diagnosis. Yeah, so there's complete heart block. Is it all? Now the patient came with epigastric burning chest pain.
Inferior STEMI, sir.
Yeah, so the complete heart block is the complication, isn't it? So inferior ST elevation MI with complicated with a complete heart,
Complete heart.
right? Okay. So remember, in complete heart block, salient point is AV dissociation. You don't see a AV dissociation. Now here, if you see the rhythm strip, is there a AV dissociation or AV association? Yeah. So what should be the diagnosis?
Second.
Inferior ST elevation MI with morbits type 2,
Type 2A.
right? 2 to 1 AV block. So
Yes.
don't jump into conclusions, just see. And remember, the salient point in complete heart block is AV dissociation, and you will see more P waves than QRS complexes, right? And Morbis type 1 is you are missing just one beat after prolonging PR interval in subsequent beats, right? So that is just heart, heart blocks. You have to know first degree, second degree, third degree, and then what is LBB, what is RBB, and then what is bifascicular and what is trifascicular. Just have a understanding, right? So this is again the same scenario we have been discussing, right? I don't want to go. So, right. Okay. So I will give you a history here. 38-year-old male patient coming with recurrent syncopal episodes, right? What is the possible diagnosis? So this is also, this has been given in your OSCE according to the information I got. So before coming to the diagnosis, tell me, what do you see in this ECG? So we'll go from that 10. Yes? Very good. There are T inversions, prominent T inversions. Is that all? Yes?
Positive AVR.
Positive AVR. Just look carefully. Is the AVR positive? It's negative, isn't it? What about the QRS complexes? Is it normal inside?
Wide.
Height is more
Wide.
V6 to
Yeah,
V6.
the height is very high, isn't it? So that is fulfilling the LVH criteria, right? Fulfilling the LVH criteria. But remember, the same ECG can come with a person who's having LVH with strain. But in that ECG, you won't have these symmetrical dagger-like T inversions. These T's are symmetrical. They are the T's are, with some ST depressions downsloping, and the T's are not symmetrical if you divide it into two, right? So what is the diagnosis here?
Left main coronary artery occlusion.
No.
Okay.
No, I told you the complaint is
Left vent-
recurrent syncopal episodes. And a
Okay.
young male. Huh?
Okay.
Okay. Left ventricular outflow record.
Yeah. Yeah, actually this is what? Hypertrophic cardiomyopathy, right? Hypertrophic cardiomyopathy. Then, so this entity you have to ask. You have to know. Hypertrophic cardiomyopathy, because we do see a lot of people here undiagnosed. Why you should know? Because they have a high risk of what?
Sudden cardiac.
Sudden cardiac death. So if they ask, what do you ask in the history? What is a salient point you ask in the history? Now anyway, they have given the patient is having syncope. One thing, if I see this ECG, one thing I will ask is whether the patient had syncopal episodes. That shows that patient might have had some hemodynamically unstable VT and a fall. And the other thing, what is the other thing you have to ask in this patient?
Family history of
Family history of sudden cardiac deaths. Right? So they don't know sudden cardiac deaths. You have to ask young people whether they have died in the family. Right? So then in these sort of people, what are the management, in management, what are the things you have to consider?
CD insertion.
Yeah, before that, how will you manage this way? Now this patient has come to you.
With
Beta
beta
block.
blockers and calcium channel blockers.
Yeah, you can start a beta blocker. So how will you? So first thing you have to diagnose. This is just the ECG.
With 2D echo.
Yeah, so
With
we
2D
have to
echo.
request a 2D echo, right? What else other? So tell 2 investigations you will do, killer. So how will you answer that question? One thing is 2D echo. What is the other investigation? Now he came with syncope. So
Hold
Carotid.
study.
24-hour,
Hold
Hold
monitor.
monitoring.
because we have to know whether the patient is going into NSVTs, right? And these people, why it is important to identify? Because they will die if we don't do what intervention? What intervention? What is the procedure we are doing? If a patient has HOCM and recurrent syncopal episodes, family history of sudden cardiac death, maybe Holter shows some non-sustained VTs or sometimes not, may not.
Right.
ICD implantation, right? So remember, people's lives will be saved if we identify this, because next time they won't come to the hospital. They will directly go to the mortuary, right? Okay. So just have this pattern in your mind, right? And you should be able to know to differentiate this with LV strain, right? Just have today itself after this lecture, type LV strain and see the difference, right? Okay. Again, what is this? This also has been given in your exams. Because these things identify save lives, like MI.
Brugada syndrome.
Yeah. So here you can't say Brugada syndrome, right? You can say type 1 Brugada pattern. Okay. Again, in the history, what will you like to ask in this patient?
Syncope attacks.
Yeah. One thing is syncopal episode. What else? What else?
Family history again.
Family history of sudden cardiac. So these two entities are very important, right? So if we see this type of ECG and syncope, we are definitely going for this thing. But remember, some people will have this pattern, but they will never come with any symptoms. So at that time, it is just Brugada pattern. You can't say Brugada syndrome, right? And if they ask what give advice you will give to this patient, advice or two, how will you advise this patient? Yes.
They get fever, it needs to be settled quickly.
Very good. So if there's fever, he has to take antipyretics and control his fever as far as possible, because pyrexia can worsen the risk of having VF, right? And remember, there's no other intervention other than ICD which can save their lives. Okay. Right. I think final few slides. So this is a 42-year-old male rushed to the PCU with a collapse, right? So he has complained of chest discomfort and palpitations before passing out. PCU, his BP is 70/40. Pass rate 180. Tell me, what is the next step in management? I will first ask that, because I have already taught you.
Sorry, DC cardioversion.
Yeah, very good. So DC cardioversion. It's not defibrillation, right? Because still the patient is perfusing, and if you defibrillate, there's very high chance that you will end up in RONT because of the tachycardia. So what is the ECG diagnosis here?
SVT, no?
Yeah. So I think they might give you marks for SVT, supraventricular tachycardia, right? But if you want to be more specific, this
AVRT.
can be told, right? AVRT, yeah. Because if you see the this rhythm strip, you can see the P waves here, see? So it is bit away from the QRS complexes. Usually, if it is AVN, typical AVNRT, it will be just embedded in the QRS complexes, right? And in AVNRT, you will see the pseudo R here, just embedded in the QRS, and pseudo S here, just embedded in the QRS, right? But this is a little bit away, right? So I think for your purposes, you can just say this is supraventricular tachycardia with rapid ventricular rate, right? Okay, and next is cardioversion. After the initial resuscitation, patient regained consciousness. This is his E.C.G, right? So what do you see here? What is the E.C.G diagnosis? Now you have the history, now you have the baseline E.C.G. So what is the diagnosis? You can directly give a diagnosis here. Yeah? Yeah, Wolff-Parkinson-White syndrome, right? Because you see the post short PR interval and then the delta waves, right? Right. Okay. What is the underlying pathology behind this abnormality?
Fast path.
Fast pathway, no, is wrong. Yes?
Accessory pathway.
Accessory pathway, right? Because in AV node also we are talking about fast pathway and slow pathway. So don't just say fast pathway, it's accessory pathway, right? What is the definitive treatment?
Ablation.
Yeah, don't just say ablation, it's radio frequency ablation of the accessory pathway. So always write the complete answers in your OSCE, whatsoever the OSCE station, right? So if it is a rash in the left hand, right, left hand. That is important, right? But usually, I mean, I just told it's just write a exaggeration, but anyway, try and give complete answers, right? To whom should you refer this patient to? Yeah, consultant cardiac electrophysiologist. So cardiac electrophysiologists are the people who are doing ablations, right? So you can just mention cardiac electrophysiologist. Name 2 drugs you should avoid in this condition. So in your purposes, it is at this time. What are the 2 drugs you should avoid? Anyone? What is the drug you can give here?
CCB.
Yes?
CCB or beta blocker.
Yeah, actually, now this question, these questions are not coming from cardiac electrophysiologists, no? So they are coming from the rest. So there's a problem in this question, right? But for you, so what they expect is, so usually in a person who has WPW with antidromic conduction, right? So there's a entity called antidromic AVNRT and orthodromic AVRT, antidromic AVRT and orthodromic AVRT. In antidromic AVRT, you will see the broad complexes, not like this. So this is actually orthodromic AVRT, if at all, right? So at this moment, actually, accessory pathway is conducting from ventricle to atrium to complete the circuit. That is why we call orthodromic. We are referring to the conduction of the accessory pathway. So if think in the antidromic one, why it is broad? Because AV node conducts orthodromically. So the ventricle get depolarized in another way, not from the normal conduction system. So the QRS will be broad, right? So in that state, if you give AV node blocking agents, it can be calcium channel blockers, beta blockers, amiodarone, whatsoever, you name it, patient can develop VF. So there's a risk of VF if patient has orthodromically conducting pathway and patient has atrial fibrillation. what we call pre-excited AF. Just have a note. I don't have the ECG here. What is pre-excited AF? So if a person has pre-excited AF, in that instance, we don't have drugs like propranolol in Sri Lanka. So we only way we can manage that patient is, even though there's good blood pressure, you have to cardiovert the patient. Right? So here they have just expected you to tell that name 2 drugs you should avoid in this condition. Any 2 drugs which is giving rise to AV node blocking, right? But actually that is wrong when it comes technically. But if they ask something like that, any AV nodal blocking agent you can write. Digoxin, beta blockers, calcium channel blockers, or anything. But the question is wrong. But remember, clinically, if a patient comes with pre-excited AF, you should not give any AV nodal blocking agents, because what will happen is you will block the AV node and all the AF impulses will try and squeeze through the accessory pathway, and it will give rise to ventricular fibrillation. That's the reason, right? What do you see here?
Polymorphic VT.
Yeah. So,
Oh, sir.
yeah. So the lower one, you can jolly well say that it's a polymorphic VT, isn't it? The upper one, it can, even you can mention it. If I will tell, even if you say it's ventricular fibrillation, I will buy it, right? Because it's so deranged. But remember, whatsoever these abnormalities are, they are very, very highly unstable, right? If a person has polymorphic VT, what is the drug you should usually give?
IV magnesium.
Magnesium
IV
sulfate.
magnesium sulfate, right? So that is a life-saving drug in that moment. And if the patient has ventricular fibrillation, what should you do?
Go for the defibrillation.
Defibrillation, right? Okay. What do you see in this ECG? It's an unsustained VT, isn't it? It's an unsustained. Can you tell about this VT? That's why I have just taken this slide. What is this VT? If you see, this is just for your knowledge. If you see the 2,3 AVF, they are positive here, see? Right? So this VT is coming from outflow tracts. Okay. And here the V1 is negative and V5 is positive. So this is actually what we call RVOT, right ventricular outflow tract ventricular tachycardia, right? So this is bit separate entity of VT, what we call idiopathic ventricular tachycardias. There are different ones, fascicular VTs, outflow tract VTs, and so on. This VT, usually VTs are not responding to verapamil, no, but this VT is usually verapamil sensitive. So outflow tract ventricular tachycardias are verapamil sensitive. So if it happens to be a tachycardia, you can always try verapamil, right? The other verapamil sensitive VT which commonly we encounter is ILVT, right? Idiopathic left ventricular tachycardia. So these people sometimes they won't even respond to shock, but they will respond to verapamil. So again, I'm sorry, I don't have that. Just review ILVT, right? The ECG, but I don't think they will give. But if you see those people as a registrar, just give verapamil and you might save the life. Or you might, prevent giving a lot of shocks and damage in the patient, right? And remember, again, a practical point, if a patient doesn't come out with the maximum shock, again, don't shock again and again and again if the patient has some blood pressure, right? You have to do some change. Either change the pad position or either give some amiodarone and then try the shock, because then you are modulating the milieu in situ environment inside. Unless you are, by giving each and every shock, we are doing some myocardial damage and stunting. So if we give 20 shocks, you can kill the patient, right? So that is also something I have seen when it comes to very bad rhythms. So don't do that, okay? Because if it doesn't come with the maximum shocks 1 or 2, then you have to do some change, unless you are doing just damage, right? So what is the diagnosis here? This is a spot diagnosis.
VF.
Yes?
VF.
Yeah,
Ventricular
So
fibrillation.
each and every one of you must be able to diagnose VF, because again, prompt and proper delivery of shock will save the life, right? Even if you do shock after about 10 or 20 minutes, then it's too late. That's why during the CPR, as soon as possible, while giving CPR, you have to connect the patient to the monitor just to see whether it's a shockable rhythm. And when we are doing cath and all inside the cath lab, if we see these rhythms, we will just shock the patient. We won't even give CPR, because we know that this is the one which is giving rise to hemodynamical instability, right? So I think this is my last slide. So remember, in your OSCE, very rarely they can give you some this thing also. Since we talked about atrial fibrillation, I have just put this thing. So in this echo, what do you see? This is actually parasternal long axis echo view. Just consider only one, all the 4 is the same. So what do you see
Left
here?
atrial.
Left atrial
Left atrial
dilatation.
dilatation.
Sorry? Very good.
Left
Atrial
atrial
dilatation is
dilatation.
there. What else?
The
Outflow tract.
Aortic stenosis.
Aortic stenosis.
was
This,
the
what
hockey
is this value you see here?
Mitral
Is
valve?
the
Mitral valve.
mitral valve,
Mitral.
right? So this
hockey
is actually
stick.
we call hockey stick appearance, right? So this is the typical appearance which comes with mitral stenosis due to rheumatic valve disease, right? Hockey stick appearance. So the valve doesn't open more than this, and that is the reason why the LA has got dilated. And they can develop the auscultation like what is the treatment modality? So at first, what will we do for the mitral stenosis? If it is suitable and no regurgitation, severe regurgitation is just the pure and simple mitral stenosis, what is the percutaneous intervention we are doing?
PTMs.
TTMC, right? So percutaneous transmitral commissurotomy. So write the long term, and then after that only the other things comes, mitral valve repair, replacement, or so on, right? And remember, these patients, if they have AF, we don't calculate the CHA2DS2. We have to just give anticoagulation. And if they ask prescription for these people, I mean not a valve but a AFib patient, you can nowadays always write DOACs. And even for these patients, if it is not valve replacement, we use it, but better you write warfarin if so, right? And you should know in OSCE setup, when it comes to AF, you should know they will ask what to do if the warfarin is, the INR is very high. So just have a small quick glance at what to do with INR 10 and INR 8 with bleeding, without bleeding, and all. It's very simple, right? Those are practical points. Okay, I think that's it. Be careful of the rhythm when they give a ECG, and whether there are any ECG changes, whether this can be electrolyte change, right? And whether this can be something which you might miss you in a usual ECG interpretation. So I haven't touched all the things, but simply things like, dextrocardia, things like long QT, right? Even Brugada you should have seen before, unless you will miss, right? Mixed up limb leads and all, I think they should not give in your exam setup. But dextrocardia, even X-ray or ECG, that's something you have to know, isn't it? Because those are people you will encounter. No? So any questions with regard to ECGs?
Sir, can you explain cardioversion and defibrillator very briefly?
Yeah, so very important. So cardioversion means we give ice for the defibrillator. That means defibrillator should know where the QRS and T is inside in the patient. So first we have to connect the leads to the defibrillator. That is number one, right? Then what will happen is defibrillator. Now you have to press the button synchronized. Then in the ECG, sorry, defibrillator screen, you will get synchronized word there, right? And then remember, when usually if you defibrillate, when you push the pedals or when you push the button, suddenly it will deliver the shock. But when you when you are doing the synchronized cardioversion, even though you push the button, the shock will come after about 1 or 2 seconds because the machine will take time to avoid giving R on T, right? So you have to keep the pedal till the shock's delivered. So only two prerequisites: connect the patient to the defibrillator and then put the synchronized machine, synchronized button, push it, and then keep the pedals till the shock is being delivered. So if the patient is not on pulseless VT or VF, always cardiovert. So it's a golden rule.
Thank you, sir.
Anything else? So I
Sir,
think
for
you have
the-
very small time for those keys. So always do the target studying these days. So just identify the pattern of, like, identify the patterns of the ECGs, identify the pattern of the sections. So mostly they will ask the same things in a different manner, right? And at least it might be the same, areas. So when it comes to ECGs, usually, like I told you, it will be the ischemia, electrolyte imbalances, and maybe toxicities. Remember, Kaneru poisoning, I haven't mentioned it here, but it is also this thing, so digitalis toxicity, right? So even patient with AF and having a CKD history, for AF, we might have started on dioxin. And patients coming with reverse tick sign or any arrhythmia associated, so it may be digitalis toxicity, right? And you have to know that you have to check the potassium level because hypokalemia will increase the risk of digitalis toxicity, and digitalis toxicity will cause hyperkalemia, right? And remember, if they ask how to manage digitalis toxicity, never if the potassium is high, you don't give calcium to those people, calcium gluconate, right? Because it can stunt the myocardium further for the digitalis, Kaneru poisoning people or digitalis toxicity, right? So, yeah, that is one thing. And then the TCA poisoning. They can give these electrolyte imbalances by, again, a history of ICU or CKD or whatsoever. And then ischemia, you should not miss. And tachycardia wise, you should not miss a VT, idioventricular tachycardia. And then you should not miss any bradycardias. And remember, when they give a ECG, always think there might be something you miss. So always think the abnormalities and then try and fit it into a one diagnosis. Okay. Right. Okay, then all those who sit for your OSCEs, I wish all the best for all of you and hope all of you will get through. And the rest who are going to sit, wish you good luck. And I think I might do another lecture on all the ECGs related MCQs, rhythm related MCQs and all in times to come. Okay. Any questions before I wind up?
Sir, in acute AF, IV esmolol can be given. What other drugs can be given other than the cardioversion?
It's like this. So if you want to achieve rhythm control as soon as possible, or the rate control as soon as possible, best is not using anything like IV verapamil and IV beta blockers, because it will further deteriorate blood pressure, number one. But remember, IV esmolol is a very good drug because its half-life is very short. So when it comes to a tachycardia, especially esmolol is helpful if you want to revert the tachycardia, like in, AVNRTs, AVRTs and all. At the same time, because the small action would last a short while, right? But unless if you want to just, achieve rate control, always better to first try the oral drugs because that will be less aggressive with regard to negative inotropic effects. But if you want to use IV drugs, you can always use verapamil. In our setup, I think mostly we don't have esmolol. Do we have esmolol in DTU? No. Yeah. Or IV beta blocker. But usually, I think in the management purposes, if you need very quick thing, cardioversion is the choice, unless you can always try oral drugs. And if you have a broad complex tachycardia, or always better to manage this as a VT rather than SVT, right? And let the experts decide on whether this is ET or SVT later. But you can, and remember, adenosine is a very useful drug in managing SVTs. And if they ask anything about adenosine, you must know a few things. One thing is adenosine effect is lasting very, very, little while, right? So you have to use it in a three-way tap and flush it as soon as possible. You give it to the patient, right? And you have to warn the patient, telling that the patient might feel a sense of doom, right? Impending doom. Like that means we are trying to achieve the total AV node block. So at that time they will feel like they are going to die. So you have to tell the patient not to be panic and stay still, because during the administration you have to take a ECG, right? So a rhythm strip. So that rhythm strip, for you to tell adenosine hasn't worked, it must have caused a AV node block. Unless the problem is the adenosine dose is not enough. So by giving adenosine, and when you are doing this, it is actually diagnostic also, because you can diagnose whether it is atrial flutter, atrial tachycardia, or AVNRT or AVRT by the rhythm strip. Because let's say if it's just atrial flutter, total QRS will be gone in that action period, but there will be the flutter waves, right? So like that. So you have to make a rhythm strip during the administration. So know about adenosine and know about atropine when it comes to bradycardias. And in complete heart block, isoprenaline is very useful for us when we don't have facilities to put a TPM. So know about those drugs because they can ask, right?
Is the VF, what is the mechanism of action in the mag sulfate? Any?
You mean the polymorphic VTs?
Yes.
Yeah. So actually it is, it comes down to this refractory periods and the membrane stability, right? So we have known that even in this refractory VTs also, magnesium plays a role in suppressing the ectopic focus due to the, suppression of the autonomous depolarization of the membrane. So they won't ask those things. Those are, cellular mechanisms, no? If at all, they can ask, the mechanism of digitalis or this cardiac toxicity, and no. Otherwise, these things they won't ask. And when it comes to ET, medication-wise in Sri Lanka, we have only 2 IV drugs. One thing is amiodarone and one thing is lidocaine, no? And again, the lidocaine proper preparations we don't have. So what we have to use is the same local lidocaine to treat these people. So just remember, some people, they don't tolerate amiodarone due to liver toxicity or so on. And then we might have to give lidocaine, right? Or lignocaine, whatsoever. Any other questions?